Hello and welcome to the Voice of the Patient podcast. We are the podcast working to change lives, that is, improve the quality of life through not only hearing, but truly listening to the voice of the patient.
Thank you for listening to the Voice of the Patient podcast. I am your host, Zach Stearns, and today I have the honor of interviewing Dr. Mark Bishop. Dr. Bishop is an associate professor in the Department of Physical Therapy at the University of Florida. Dr. Bishop received his entry-level training in Australia and has extensive experience working as a physical therapist. His research interests are in the management of musculoskeletal conditions, particularly pain, by orthopedic physical therapy. And lately, Dr. Bishop has been spending a lot of time researching expectations and other nonspecific effects. So first, Dr. Bishop, thank you very much for coming on to the show.
Oh, you're welcome. Glad to be here.
Good. So I wanted to explain that first, Dr. Bishop and I go back to my first day of class in physical therapy school as I am a student now for another month, hopefully, at the University of Florida. And as far as learning more about expectations, I have seen that there's really an important role of expectations for us as providers in rehab in general and also in physical therapy. So first, Dr. Bishop, could you define what those expectations are and how you've been involved in that research?
Yeah, sure, Zach. I'm going to start out fairly broadly. So if we think of the global general term as actually expectancy, so expectancy is kind of this much larger term, and then the expectation is a very specific thing that you want to happen based on expectancy. Conceptually, a lot of this comes from clinical psychology, obviously, and I would encourage people who are really interested to kind of move into the clinical psych literature to get really more grounded in there. But social cognitive theory, we're kind of thinking that people generate an association between a behavior of them or someone else and an outcome. And so that's really what an expectation is somewhere you either have a current association or you will later build an association between something that happens that you do or someone else does to you, and then the outcome that happens afterwards. And I think when I have read about it and thought about it, that seems to me to be the simplest way to conceptualize expectations in general. I know you're talking about the expectations of patients coming to see us, but, you know, we're also talking about my expectations as a provider come into play very strongly with these type of things. Mm-hmm. And then the second part of your question, I think, was kind of defining those a little bit better. You know, when Joel Bialowski first started looking into this in his dissertation and we started looking at the literature, we were following some stuff by Thompson and I think you say it's Sunnell. I'm not sure of the pronunciation. But they were really looking at categories of expectation related to patient satisfaction with care. And these are the terms people may have read in our work: normative, predictive, ideal, and unformed. And maybe as, you know, this is a pretty big field now. There's several journals specifically dedicated to healthcare expectations where that's all they publish. And there's conceptual models that have built much more broadly than that Thompson and Sunnell model, but you know, we're still kind of left with these broad ideas of normative expectations being what do you kind of just generally expect is going to happen? Are you going to have a chair when you get to sit down? You know, is there going to be a receptionist? Those are sort of one level of expectations. But then the ones that I think really impact certainly me as a healthcare provider, the expectations about what's going to happen in the interaction between the patient and me, what's going to happen when we do a certain treatment, and these are kind of predictive expectations. What do I think's going to happen right now after this interaction? And it's the predictive ones that I find pretty powerful when I'm thinking about treatment outcome and those type of things.
So predicted expectations, not just from the patient, but also the provider of how the treatment is going to go.
Yeah. I kind of got turned on to it. Chad Cook did some work in equipoise. And equipoise is this idea in a randomized trial that whoever's delivering the intervention doesn't really care what intervention it is, so that you're equally in favor of everything. Well, I'm a huge proponent of manual therapy. I believe strongly that my powers as a manual therapist, my abilities and all that type of stuff are really effective. So I am not unbiased at all. I'm hugely biased when I interact with you because I believe very strongly in manual therapy, and I expect that if I treat you with this manual therapy intervention that you will get better. And so we've done a little bit of work in looking at our own data where the provider expectation really significantly affects the outcome much greater than the actual intervention provided, which we found pretty strange, that it didn't really matter what intervention the providers gave. If they believed very strongly in something, the patient got better. Mm. I mean, I don't know if that was clear.
No, yeah,
so
absolutely.
If I can give away the thing, it was 3 of us who believed very strongly in manipulation in a study, and then another one who had perfect equipoise. Well, it didn't matter if the 3 of us who believed in manipulation, if we did a touch-only intervention, we still got more pain relief than the person who believed equally in every intervention. So there's something about that, my self-efficacy, my strong belief that I can make a change, that is a very powerful impact on that interaction. And when I say it like that, I think intuitively every clinician is saying, oh, well, of course. I went in confident with my abilities to perform the technique, even though it's not my favorite technique. I am still very good at what I do, and I expect you to get better. Turns out you get better.
Mm. I have a lot of reactions to that. I think the first one is that it reminds me of, actually at CSM, there was a great Oxford-style debate about dry needling. And this, as the debate was terrific, it was two therapists arguing in favor of using dry needling, and then 2 not in favor. And as I heard the debate, I think points were great on both sides, but I actually was wondering about this, that if these 4 therapists were to suddenly start using dry needling regularly, I think 2 of them would have pretty good outcomes. And I then thought that, is that really controlled for in the literature and in some of the literature for really any interventions, but particularly for dry needling? And I wondered that. Could you talk about the history of accounting for that in trials?
Certainly. So if we're specific to manual therapy interventions, for example, then no, they're not really accounted for very often. And to be in full disclosure, I haven't read broadly through this literature, but I know Dr. Cook's paper in, I think, around 2012 was the first time I'd really thought about our studies that we were doing. And so we have included the provider expectation in all those studies. I would say that in papers I've reviewed recently, I have not seen that at all as something that people are collecting, and I would encourage people to kind of either measure that. I just don't know how much equipoise is out there. Mm-hmm. Mm-hmm. Do you know what I mean? So yeah, I think everyone probably expects something to work better than something else, and that's why they choose to do it.
Right, and that's where our biases are. And then I wonder about the research that is generated, because really, if someone's interested in something, it's usually because they believe in it, or that they think that there are effects of it. Then as far as finding therapists willing to participate in the trial, then they just may end up forming that network of therapists who also have similar thoughts about an intervention.
Yeah, and I think that this is the basis for why people recommend pragmatic trials over randomized clinical trials, that pragmatic trials are going to be, I don't know if easier is the right word, but potentially successfully capture this information better than a randomized trial.
Mm-hmm. One question, though, is as far as clinicians moving forward with trying to, one, practice in a way that is evidence-based, but two, having good outcomes. It then creates an interesting dilemma for me because I think I should learn a whole lot of interventions. I should be good in a wide variety, but that might include some interventions that I might not be thrilled with. Say, for example, what if I have ligamentous laxity in my hands and I feel like I'm never going to be all that great at manual therapy? However, I know that there will be some patients who really will want that and want that from their provider. So then I'm faced with this interesting issue that I might not be all that confident in my abilities in manual therapy. However, I should improve my skills in manual therapy. I don't want to be in this position where I don't have skills, but I also am in a position where I question how good I will end up being. So then it leaves, I think, students and maybe some providers with an interesting issue of, should you be strong believers in all interventions, or should you pick ones? But then if you pick ones, is that evidence-based practice?
Well, I can see a whole lot of pathways through this particular puzzle you've presented here. So my first response to that, and this I will try and say this as gently as possible, that there may not be a big difference between lots of different philosophies of manual therapy when it comes to treating pain specifically. And so certainly in the large, broad trials, that when you compare interventions head to head, you don't see any differences between them. So then that would suggest to me that if you can find one that you can do, you like, and you're confident in doing, that you should be able to use that as an intervention. Mm-hmm. So then if I extend that, I would kind of encourage you to find techniques that have some sort of foundational underpinning, so you can be confident that you're providing something in a way that you're comfortable, that it's a technique that has some support. But as long as you like to do it and you're comfortable and you have good self-efficacy about it, then I think that you will get good outcomes even if you're not doing the alternative technique.
Mm-hmm. Sure. Really, this going back to the debate on dry needling, and I will set the whole debate on that aside, but going to an extreme. Say going to an extreme of picking an intervention that it's not just as good as other interventions, but there is very much a lack of evidence that it offers anything above a placebo effect. So this comes from discussions that I've had with Kenny Veneer, who's actually one of the therapists in that debate on dry needling. And a lot of his blog at physiologicalpt.com has worked with discussions about the type of interventions that we choose. And so he offered a really great question, which is that what are your thoughts on clinicians justifying the use of treatments just based on expectancy, period? But there might not be any evidence suggesting that the treatment has any intrinsic efficacy. Could you talk a little bit about that? And I think that there are some absurd examples of like bloodletting, that no one does that anymore. And then there are plenty of other examples that are very common practice.
Yeah. So let me just clarify, when you say based on expectation, you're really talking about this idea that there's something that we do that has an active component. So the underpinning assumption in your statement is that you're doing something that actually has an active ingredient, as it were. And right now, that is a very hard thing to prove for a lot of interventions. But let's do the thought experiment, and we'll work on that. Yes, there is something active. For example, for a while there, we thought that the velocity of the contact is why manipulation was important. So there's obviously force parameters and those type of things that you can examine. The other thing that you mentioned was an intervention that was not better than placebo. And I'd encourage you to kind of reframe that statement potentially for yourself and for people listening to say that, placebo is an active mechanism and not an inert thing. So when something works through the placebo mechanism, you get physiological changes in the periphery, neurophysiological changes in the center, you get hormonal changes, you get a massive cascade of events that happen as the result of a sham intervention. And so the issue not really is the intervention the same as the placebo and therefore they're both worthless? It's, is the placebo better than doing nothing? Because if the intervention and the placebo are both better than doing nothing, then they're both better than doing nothing.
That's a good point.
They may work through different mechanisms that we don't know. They may work through the same mechanism, but we'll assume they work through different mechanisms if you believe that your manual intervention has an active component. So in that light, if I have an intervention that performs as well as a really good sham, and both those things help the patient more than doing nothing, then I would say do the intervention.
It's a good point, and it touches on the specific active mechanism of placebo, not just being worthless, but really that there's an active component to it. And if it is better than nothing, then it merits a different type of discussion. But there's still some, I'm going to say, counterpoints.
Sure.
And a couple of them being depending on the type of intervention you're using. One, is it an intervention that doesn't seem to have a biological plausibility? And so these might be some interventions that have either gone out of style, but also some that have become more popular lately. That if you were to explain how it works, that it might not even be consistent really with itself, or consistent with evidence about anatomy and physiology. So a good example would be like bloodletting, that it's not consistent with our understanding of the human body. As far as interventions like that, first, what are your thoughts on any other interventions?
Well, I think this is just for me and just opinion. I think that my preference is to use something that at least has a foundational underpinning that I can look to and say I can buy into the neurophysiological theory behind that or the mechanical theory behind that, and I understand those theories. So for me, that's the criterion. I would have to say that those criterion have been flexible. I did my training a while ago, and in the 80s when I was learning manual therapy, that I was sliding joint surface together at some point, lubricating joint surfaces and stuff. And that as a mechanism of why the mobilization helped has kind of gone out of favor, but I still think joint mobilization has great efficacy, and I employ it regularly particularly to manage pain. So I'd say that some of that stuff for me is flexible, and potentially there might be an intervention that I don't believe in much right now because I don't agree with, theoretically I can't see this having a biological value, that might change. The other thing is there's a part of me that says if we can get away from this negative connotation of placebo, what if we changed the name and I said I was actively engaging downward modulation of your endogenous pain modulatory system? Would that be a better intervention? I just had to do it by laying hands on and something. Mm-hmm. I don't know if I'm completely there yet, but there is part of me when I do a lot of this reading and the work that we have been doing that looks at if I can engage the same pain relief with a sham intervention of lower risk, that maybe there will be a time where I choose that. Right now, I don't. That is not how I work, and I still think about the biological plausibility. But I got to tell you, I'm getting closer that if I can find something that's got a low risk, low sort of high reward intervention, gets the same or as equivalent results or something like that, then
Sure. I think it's a really great point, and the way that you had defined placebo is much more impressive just than the word placebo, because we end up defining placebo in things that it's not, and we end up thinking that it means nothing, but that's not the case. But let's take the argument into a different direction, which I hear very often, and honestly, it's something that I feel sometimes too. Is what if we're put in a position where we're not better than the pain relief aisle at a pharmacy? If we're not better than walking down and seeing a lot of gadgets and gizmos or straps or lotions in the pain relief aisle of a pharmacy, then I'm challenged, because I'm wondering of how ethical it is for me to bill insurance when it might not be any better.
Yes. So I have thought about this quite a bit, and I have a couple of thoughts for you. I'm going to assume we're still talking in the context of engaging endogenous downward modulation for pain relief, yes, causing an active cortical neurophysiological effect. That happens best in context. The context in which it happens best is a highly structured examination from a trained practitioner who is knowledgeable, performing a complex activity. So all those things actually still have to happen for you to engage this neurophysiology. I can't walk up to you and do something without all the context and the expectation and the learning. So it still takes a lot of effort to get that to happen. And so when I think about it in that way, I can't effectively engage your own endogenous pain modulation without having done everything behind the patient encounter. And that includes my training and your expectations and my expectations and everything. So in the end, in that model that we were just talking about, the final point of delivery is only that. It is the final point of delivery in this giant context. And so in that model, when you talk to psychologists, sometimes some psychologists don't really see what we're all bent out of shape about. They say, well, that's just the delivery device. It doesn't really matter. But, I'm fairly sort of profession-centric. And I say, no, this is very important that I do it in this way. And then the psychologist will say, no, that's important for you to maximize your expectation for the interaction. But still, if it's important for me to maximize that, then that's where we go. Now, that was all a thought exercise, right? I'm saying that outside our profession, there's some people who say as long as you can engage the pain relief, the delivery vehicle may not be as important. But I personally can't get to the point where I can say, I know the majority of this is your intrinsic pain modulation. I just built up a whole therapeutic milieu around you to do this thing. I mean, I still need that information. I still need to do the exam to work out which of the techniques I'm going to choose to do.
Right.
And I know I talked all around your question and didn't answer it all.
Well,
but
I think that you did, because really you mentioned the importance of the context of the context of treatment, but the context of the relationship between the provider and the patient. And that doesn't happen just buying a product off the shelf and having the shelf sit in your home.
No, that context's been built for you by marketing and TV and social learning. In PT, we don't have that. Maybe if there were giant media campaigns and everywhere you turned, there was smiling PT doing something and someone getting better, we'd have a social learning context where everyone says, oh, PT, I feel better already.
Yeah.
But we don't have that. Right. And so we need the patient encounter to kind of generate that context.
Sure. Now, also, as far as expectancy, we've spent a lot of time talking about that on the part of the provider, but also a lot of your work has dealt with what patients expect to happen.
Yes, sir.
Could you talk a little bit about the type of expectations that are important on the part of the patient? First of all, are there different types of expectations, and which ones are most relevant for therapy and success in therapy?
Yes, I'd say from some of our work we've seen how very general expectations have been important. And these are the type of expectations where I might ask you, how likely is it that you will be completely better? I can't think of the exact language now, but do you expect to be completely better? Recovered. Do you expect moderate relief? There's all these type of questions, and I can look up the language if you want. You can ask about exercise or sleep, for example, in some studies that Josh Cleland and Paul Mintgen have done. They've asked about those things, as well as the expectations for individual interventions. So we've analysed some stuff. Josh and Paul have collected information from the patients about, how much do you expect manipulation or massage or exercise to help this episode? And we've seen that those have had some impact on outcome, particularly if you can match a patient's expectation with that intervention. But the general ones kind of interest me. And we're not the only people to have seen this. There's some work by a fellow named Parmoff. And I think they asked, do you expect to be completely recovered in 7 weeks? Like, they were very specific about a time frame.
Okay.
But just still that general recovery expectation. And people who expect to recover, don't be surprised, they're the ones who are doing better at 1 month and 6 months.
Right. So really, what they predict will happen leads, and it makes perfect sense.
Yes,
right?
I don't know if your grandmother said it, but think positive thoughts. The good will come. There's an element of that when I look at this data and I say, wow, the people who say, yes, I will be completely recovered in 6 months are the ones who say, yes, I'm very much improved. Thank you very much.
So I think it's very important for clinicians to find ways to incorporate a lot of this into practice. And I remember seeing a paper, one of the papers that you co-authored, that at that point there wasn't really a good standardized measure. And since then, I've seen a couple other methods used in some of the literature. Could you talk about ways that we could actually assess expectations of patients?
Yes, there's the issue that there's still no great single omnibus tool for everybody to use in every setting for every intervention. There's been a couple of developed that are like yes/no questions, like do you expect to recover? Do you expect less pain? Yes, no. And those ones seem to have, they've had done psychometric testing and they seem to have pretty good psychometric properties. I really think the simple one item, single one item questions are the easiest to implement clinically, because then I know, are you expecting to recover coming to PT? Yes? Good. All right. Which of these interventions do you expect to help you the most? Okay. Good. And I think that clinically then that helps me guide my treatment a little bit, particularly if I interact it by saying, here's some interventions I really like to do for this condition. Which one of these do you expect to help the most? Great, I love doing that. And if that perfect storm comes together, then I would say that's someone who's going to go well. I believe probably that the more helpful example would be a patient, and everyone's had the person who comes in and say, well, do you expect to get any better? I don't know why I'm here. I got sent here. And so you're going to have to spend some time modifying that person's expectations. But I really think those simple questions are the best ones to implement clinically, because they're rapid, effective. They can be part of the treatment planning with the patient.
And that brings a good issue. It brings an interesting issue, and this is something that Jerry Durham actually mentioned that he was curious about is, what do we do with someone who comes in and has no expectation? They don't even know, maybe they have something that's unusual that they have not heard of before, or maybe they just don't know how rehab works. They don't have any idea of what to expect. What should we do in that situation?
Well, obviously, I think that is fertile ground to plant some very positive information about the rehabilitation care provided by physical therapists. Obviously, the information has to be factual and truthful. You can't oversell something that's not going to happen. And if there's bad news to tell about a condition, that bad news can still be presented in a way that is not completely devastating to the person's hopes of changing their current condition. But if all their expectations are currently unformed, then the interaction with you or me as the provider becomes a very important time. The other things that you can do to help someone with unformed expectations is have a therapeutic context that is all about recovery. Some people do this brilliantly, either intuitively or explicitly, but you walk in, there's the signed pictures and the thank yous of the incredible care. There's smiling people doing well that you're interacting with. The very first person that they call, who maybe is making their appointment, and say, oh, this is your lucky day. You actually have an appointment with Zach on Monday. I love Zach. He is great. That all those sort of things in someone with unformed expectations, that all those sort of things are they may not make like super effective things, but they're all beginning to set up these normative expectations that hopefully then will fall over into your predictive expectations. And so social learning, of course, plays a big part. And so that's the whole, your reputation, having people in the clinic who are doing well. When someone with unformed expectations comes in and they see someone have an adverse reaction to a technique, then, that sticks. But if they see someone having a great response to a technique, that sticks. And so certainly in the pain literature, we know if you as the participant see me do something to someone and they get up off the table and say, I feel awesome. So I think that therapeutic context comes into play with the person with unformed expectations. And so there's lots of things that people can do in their clinics to kind of maximize those type of things.
Good. Awesome. Now, as far as other types of research moving forward, is there anything to keep in mind, or any other any other questionnaires that we could consider using in clinical practice, or any other directions in research about expectations?
It's a really thought-provoking question. I know that there's some things that Dr. Bialowski and I and Steve George had talked about where we're looking at matching a little bit better. We did not find what we expected when we originally did some retrospective analysis of whether I like to do manipulation, you, the patient, like to receive manipulation, and I give you manipulation. I mean, we thought that combo would outperform all others, and it really didn't. So we'd kind of like to know why. You know, obviously it was retrospective. We'd like to set it up prospectively where we can actually control the expectations and do a little bit more education that way. That's where I would like to move ahead going forward, is looking at this kind of interaction, therapeutic alliance related stuff. Particularly my interest is in pain and pain management. So, that's where I think it would like to go, certainly for me. I know that some other really interesting questions that we've sat and talked around about is some of the imaging stuff, like, is expectation affecting what part of the brainstem and some of these things, and that's very mechanistic and probably not got any direct application to clinical practice for a while.
Is one possible hypothesis of that, say you provide manipulation and you believe in it, and your patient really expects good results from it, but what if you just don't get along, and what if your patient is doesn't get excited about coming to see you, doesn't get along with you, you don't have a fun time there? And so I think that sort of touches into part of the therapeutic alliance.
Yeah,
is that one possible?
Absolutely. And so that's back to context. And so all these different things, to maximize the benefit of the expectations, you kind of need to be considering all of the parts. And yes, if the person believes very strongly in manipulation and gets manipulation from someone who likes to do it, they will probably have a good effect. But if they believe very strongly in manipulation, get it from someone who likes to do it, and really likes the person who's going to do it and has a good positive relationship, they will get an even bigger effect. Right.
Absolutely. Great. Well, as far as any final words of wisdom for clinicians, any big major takeaway things that there are some things that we need to do to change our practice about your research, what would you tell them?
A couple of things, I think. I don't know if this is shameless plug activity. Joel just finished writing a viewpoint for JOSPT about placebo. And in that, we're kind of making the point that placebo is not inert and placebo is not negative. Placebo is an active process, and if it helps to change the name to endogenous pain modulation, we happen to think that might be a good idea. So you can say, I'm doing a technique that requires manual contact and force applied in this direction to engage your endogenous pain modulation. That I think those type of things may get us away from the debate about inert, nothing, whatever. So I think that's one level. I'd also say that I'm in no way suggesting that all the training someone does is not important. All the training that someone does is incredibly important in their skill and their presentation and that whole therapeutic context. So without that training, the person can't be as powerful as they are. So that still has to happen. I would just say find or identify a manual therapy, and this is manual therapy centric, find or identify a therapy that you enjoy, that you like to perform, that you believe in, and get really good at applying those techniques. Would be my advice to a novice clinician. And they would probably be the two take-home things. I'd say if people get interested in the placebo part of this, there's some really good work done by some Italian neuroscientists. One is Fabrizio Benedetti, who's written some outstanding review papers that are pretty easily consumable. And these aren't just pain, by the way. These are movement and Parkinsonism and disease states and a whole host of things. And then another one is, I think you would pronounce it Colica, Collloca, has also done some very nice review papers, as well as the empirical studies, but the reviews are pretty accessible. And if people are interested, those could be good names to be looking up and reading.
Great. Well, thank you very much. And how can our listeners reach out to you with any questions or
Sure,
thoughts about
they
it?
can tweet at PhysioBish. Could send me an email. It's bish@ufl.edu.
Great. Perfect. Well, Dr. Bishop, thank you so much for coming onto the show. I really appreciate it. To our listeners, if you enjoyed this episode, if you have a story to tell as a patient, provider, or both, then please let us know. Please reach out to me on Twitter at Zach R. Stearns or to Dave Reed at DReedPT. Thank you for listening, and keep listening to the voice of the patient.
If you enjoyed this episode, go to thevoiceofthepatient.org, where you can find other helpful podcasts and blog posts that will show you how to improve healthcare through not only hearing, but truly listening to the voice of the patient. Thanks for listening. This podcast is brought to you in partnership with the Senior Rehab Project at seniorrehabproject.com.